Hi, my name is Arian Rahim and welcome to today's session with a focus on abdominal x-rays. In this session we will be going through a range of common cases with images to illustrate what you might see. It would be beneficial as we're going through the cases to pause the talk and test yourself before going through the answers using the ABCDE format that has been taught in the introductory session. If you have not watched that yet, I would highly recommend giving that a go before attending this session. So the basic rules of interpreting an abdominal x-ray, you can look at your approach, so look at the details of the patient, the posture and projection and exposure. So usually the radiographs are taken supine or lateral decubitus and they're usually AP. They are meant to include from the costal margins to the pelvis, including the ischial tuberosities if AP. And it's good to look at previous scans for comparison to see if anything's changed between the time the last one was taken. And then in terms of handy things to help you remember how to interpret abdominal x-rays, you can use BBC, so that's bowel for the first B, looking at small, large and cecum, bones and calcification, and then at the end you can add artifact. Or for a rhyming one, you can use gases, masses, bones and stones. But generally the small bowel is found in a central position with valvulae convergentes. Those are the mucosal folds of small bowel that cross the full width of the bowel. And large bowel is found peripherally on the radiograph with haustra, which are mucosal folds that do not go the whole way across and may have visible feces within them. With the cecum, it's useful to remember the rule of 3, 6, 9. These are in reference to centimetres, which is the upper end of what size the bowel should be. So the 3 is in reference to how big the small bowel should be, 6 in reference to the large bowel, and 9 centimetres is in reference to the cecum. So if it goes above those measurements, it's considered dilated. So we'll start off with case 1. I would take some time to pause the video and have a look at the image and try and come up with what you think is going on before we talk through it together. So here we have multiple central dilated loops of gas-filled bowel with valvulae convergentes going through, so you can tell it's small bowel. This image is illustrating small bowel obstruction. You can see that the small bowel in the left abdomen, if you measured it, would be dilated up to 6 centimetres in diameter. What we can see here are some surgical clips, which begs the question that maybe they've had recent surgery and that the cause of the bowel obstruction could be an adhesional small bowel obstruction. And in terms of common causes of small bowel obstruction, adhesions are one of the most common of the lot, and others can be hernias, IBD and malignancy. This is another slide that's illustrating much of the same. You've got multiple loops of small bowel that are dilated. You can see the valvulae convergentes, and it's bigger than the usual 3 centimetres of what it's meant to be. And to really hammer the point home, here's one more example of small bowel obstruction. You can see that they've labelled the size 5 centimetres there, but again it's centrally located, dilated loops of bowel. You've got the valvulae convergentes and it's central, so you can say it's small bowel. And again here it looks like there's an anastomosis here, so recent surgery, probable adhesional small bowel obstruction again. So for case 4, again, pause the screen, take a moment to think about what this might be, and then we'll talk through it together. So this image is demonstrating large bowel obstruction. So you can see more peripheral located bowel with haustra, so it's not going all the way across. It's much larger than the previous images. You can't really tell for sure here, but in this particular case it was a diverticular stricture causing the large bowel obstruction, with the transition point at the sigmoid colon, which takes us through to common causes of large bowel obstruction. So again, malignancy is one of them, diverticulitis, so in this case it was a diverticular stricture, and volvulus is the other common cause. So here we have another case. Take some time to try and work out for yourself what might be going on here. So this is quite a common one that comes up in med school. It's a sigmoid volvulus, and that occurs when the sigmoid colon twists on its own mesentery, and it has the classic coffee bean sign. So the bowel just looks a bit like a coffee bean. And again, you can see that there's dilated loops of large bowel, it's peripheral, it's much bigger than the small bowel, and the lines aren't going all the way across, so it's just haustra that we've got here. So this is a very common case that will show up in medical school as well. This is Wriggler's sign. So when Wriggler's sign is positive, it is suggestive of air on either side of the bowel wall. So that's allowing visualization of both sides of the bowel wall. And basically this is caused when there's a perforation. In this case, it was a small bowel obstruction that caused the perforation. But you can see that both sides of the small bowel are clearly seen in the image. So that's highly suggestive of a perforation, which is, as I'm sure you know, a surgical emergency. So here, take a moment to pause the screen and look at case 7. So the findings here aren't terribly remarkable, but on the right we've got a total hip replacement in situ. There's no evidence of loosening, no periprosthetic complications, and it looks like alignment is maintained in comparison to the left. The left hip joint, there's some early degenerative changes noted, and same with the lumbar spine region, there's some early degenerative changes noted, and a bit of feces in the colon, but not much else to say here. But in comparison to this image, which also has a left hip hemiarthroplasty, there are severe degenerative changes in the lumbar spine and in the right hip joint. So you can see a severe loss of joint space on the right hand side. And with the degenerative changes at the lumbar spine, you can see that there's a severe loss of disc height and joint space narrowing. But the bowel gas pattern in this image is unremarkable. There's no signs of obstruction and no obvious pneumoperitoneum. So take a moment to look at this image and then we'll talk through it. So here we have an example of fecal loading in the colon. You can see the pattern of fecal loading here. But the bowel is within normal ranges of size, so it's not dilated. And if you look closely, you can see here that there's an IUD in situ. So for case 10, we have another abdominal radiograph, and the obvious pathology on here is the density on the left-hand side here. This is a left-sided kidney stone in the ureter, and it's the calcium-containing stones that are radio opaque on x-rays. And about 80 to 85% of kidney stones are calcium containing. So like I said, about 80% are calcium containing. The most common types are the calcium oxalate and calcium phosphate. You've got struvite, uric acid and cysteine containing stones as well, and the various percentages are as illustrated on the screen. But that's a common question that you might get asked. So now we're just going to do a brief run through of some common cases that you might see as an F1 on general surgery and their relevant imaging as well. So for a bit of background, we've got a 45-year-old female who has a high BMI who is presented to A&E with right upper quadrant pain, which is Murphy's positive, and vomiting. Just take a second to think about what investigations you might order for this lady, especially imaging. So the imaging modality of choice in this case would be an ultrasound of the gallbladder. It's mostly preferred as it's non-invasive and about 95% accurate in detecting gallstones. It can also detect pericolic fluid and a thickened gallbladder wall, which can be identified in acute cholecystitis. So here we have an example of an ultrasound abdo looking at the gallbladder, and as we mentioned before, signs of acute cholecystitis can be a thickened gallbladder wall. So if you look at the wall up here versus down here, it's much thicker. And then what you can also see is the little bunch of stones that are here in the corner of the gallbladder and the associated shadowing coming off from where the stones are all suggestive features of gallbladder stones and possible cholecystitis as well. So the next case we have here is a young man who's presenting with right iliac fossa pain, rebound tenderness, pain on percussion, rigidity and guarding. And again, I'd just like you to take a second to think about what kind of investigations you would get for this gentleman, especially what imaging you would like. So in this case, I think it would be useful to get a CT Abdomen Pelvis, querying something like an appendicitis or a perforation as well, as it is highly suggestive with the right iliac fossa pain and the rebound tenderness. The majority of the time, appendicitis is a clinical diagnosis, but getting a CT scan can help aid the process. So we got a CT scan for this chap, which is the preferred image modality, as it's up to 97% specific for the diagnosis of acute appendicitis, but also allows for alternative causes of abdominal pain to be diagnosed as well. So as an F1, you won't be expected to be able to make this diagnosis just from the CT images. You would just wait for the report, but just some fluency and familiarity with the images can help. Some common signs that are seen on CT for appendicitis is an increase in appendiceal diameter. So if you were looking at the images and decided to measure from the outer wall to the outer wall, it would be raised to above 8 to 9 millimeters in acute appendicitis. You can also look for wall thickening in the appendix, so anything above 3 millimeters, would be suggestive of an appendicitis. And in this case here, you can see quite an enlarged appendix, which is highly suggestive of an appendicitis. So the last case that we have here is a 70-year-old gentleman who's not opened his bowels for a couple of days, and he's now vomiting up fecal matter and in severe pain. Again, I want you to think about what you would do in this scenario and what investigations you might order. So it sounds like this gentleman is in small bowel obstruction, and immediate management of this would involve nasogastric decompression and intravenous fluids. I'd like you to see if you can remember the most common causes of small bowel obstruction before we move on to the next slide, where we will see an illustration of one of the causes on CT. So here we have a cross-section image from the patient's CT scan, where you can see here that he has an umbilical hernia coming through his abdominal wall here, which was one of the most common causes of small bowel obstruction. But again, as an F1, you wouldn't strictly be expected to be able to diagnose this yourself from the images, but the clinical diagnosis and initiation of the management plan shouldn't wait until you get confirmation of the diagnosis from the scan. So that concludes this very much whistle-stop tour of abdominal x-rays and common cases that you might see. Thank you for attending the session, and please fill out the feedback using the QR code on the screen. If you have any questions, please contact the course lead. Thank you.